Now it's going live, ma'am.
Okay.
Suman.
Got it. Okay.
Good evening, doctors. I Shuman on behalf of Shield Healthcare, welcoming you all in today's session on this pelvic inflammation disease and female infertility. And our guest speaker is Dr. V. Sarada, madam. And it's my honor to introduce Madam. Madam did an MBBS DGU DMRT and Diploma in Reproductive Medicine from KIL. Madam is trained in Reproductive Medicine in ERT, Triple Chennai, IDK Ahmedabad. And apart from that, in terms of presentation, Madam participated in many national and international conferences, and presently Madam is associated as a consultant at Rohini IVF Center, Amalapuram. So with this short introduction, I request Madam to take over the session, and meanwhile I request all the participants for your active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion with Madam. So thank you, Madam. Over to you.
Okay. Okay. Good evening, everyone. Am I audible? Yes. I'll share my screen. Can you see my screen?
Yes, ma'am. Yes, ma'am.
Can you see my screen?
Yes, ma'am. We can see.
Okay. Shall I start?
Yes, ma'am.
Okay. Good evening, everyone. A warm welcome to all of you. Sorry for the interruption. Actually, we started the seminar, but again, we are restarting it for those who have started seeing late. Today, the topic of discussion is pelvic infection disease and female infertility. Okay. I particularly choose to speak on this topic today because I thought we as gynecologists and obstetricians should recollect our teachings of our medical school, especially the main basic clinical examination, history taking, per speculum examination, and per vaginal examination, which we have forgotten in our COVID era because of the non-touch techniques. Now that the pandemic is ending, I think it's better we go back to our basic teaching of doing a clinical examination, good proper history taking, a per speculum examination, and a per vaginal examination, without which especially a pelvic infection disease cannot be diagnosed. No matter whatever the advanced we are in our technology of diagnosis, we have to do the fundamental examination for
What are you saying? Hello?
యాకే గారు మేడం కాల్ చేయండి. ఇప్పుడు మనది ఏం ఇష్యూ లేదు, మేడం కడేమో టెక్నికల్ ఇష్యూ ఉన్నట్టుంది. సో ప్లీజ్ కనెక్ట్ విత్
Sir, hello. Hello.
Start video. Hello.
Yeah, yes, ma'am. Now,
Yes,
okay.
madam.
Ma'am, you can start, ma'am.
Okay, I'll start the session again. From the beginning.
No, ma'am. Just now where you stop, no, ma'am. From there you can.
Okay. Okay, an overview of pelvic infection. Okay. The pelvic infection disease is a major comorbidity in young sexually active women. As we all know, the prevalence of pelvic infection disease is being increased worldwide. It usually results from sexually transmitted pathogens that are ascending from the lower to the upper genital tract. As the picture on the side of the slide shows, the bacteria enter through the vagina, through the cervix, into the uterine cavity and the fallopian tubes and the ovaries. And it is so important because it can have long-term sequelae. So this is a picture. If the ovary is infected, we call it as oophorytis, and the tubo-ovarian is infected, they form tubo-ovarian abscess. If the endometrial cavity is involved, it is endometritis, and the fallopian tube, the salpingitis and hydrosalpinx. And finally, the peritoneum gets infected. We have the pelvic peritonitis and pelvic abscess. Now, the pathway of infection is usually an ascendant infection. Because it starts from the cervix. Sometimes the infections are involved as blood-borne infections. So the lesions are usually generally bilateral, though sometimes a single tube can be affected at times. But the ovaries are so closely linked to the fallopian tube anatomically that they are coincidentally involved in the infection. Except in case of mumps, the two organs are simultaneously involved. That is, the tubo-ovarian as a unit is generally involved. In mumps, we find only oophorytis. So the pathway of ascending infection is cervicitis, endometritis, salpingitis, oophorytis, tubo-ovarian abscess, and finally peritonitis. Now, why are we scared about a pelvic infection disease? We are scared because it leaves long-term sequelae. What are the long-term sequelae of a PID? That is, it causes chronic pelvic pain in the patient, infertility because of the bilateral tubal blocks, and ectopic pregnancy, again because of the tubal block. Now, what are the causative organisms in case of PID? The slide only shows here main two organisms, that is Neisseria gonorrhea and Chlamydia trachomatis. But we all know that PID is a polymicrobial infection. It can be divided into sexually transmitted infections and pyogenic infections. Now, sexually transmitted infections, we have the gonococcus, chlamydia, microplasma, and trichomonas. And in pyogenic infections, we have the aerobes and the anaerobic infections. Aerobes, we have the staphylococcus, streptococcus, as well as E. coli. And in anaerobic infection, we have bacteroids, clostridium, and actinomyces. Actinomyces, especially it is associated with IUCD insertions, as we all know. And tuberculosis has to be mentioned in case of pelvic infection disease only, though it itself is a huge chapter with involving so many aspects. But I would like to touch upon tuberculosis also in 1 or 2 slides. Let me tell you that the diagnosis is not just made by a simple lab testing, but it is an amalgamation of symptoms, signs, and office-based testing. Now, the two main infections are Neisseria gonorrhea and Chlamydia trachomatis. And other infections are Gardnerella vaginalis and anaerobes. Now, who are the people who get PID? This is the younger age group, less than 25 years, who are sexually active, and patients with multiple sexual partners with a past history of sexually transmitted infections and history of any termination of pregnancy, MTPs, which needs instrumentation, And procedures like the IVF procedures, which is hysterosalpingography, hysteroscopy, and oocyte pickets, are inherited with are prone for pelvic infection disease. And smokers, because of the decreased resistance, they are prone for infections. Coming to symptoms. Now, what are the symptoms? Sometimes the patient can be totally asymptomatic. We have to elicit it by our own signs of an clinical examination and a proper history taking. Now, if they are symptomatic, what are the symptoms? The patient presents to you with a typical bilateral lower abdomen pain at the site of the tubes, a temperature more than 38 degrees centigrade, a deep dyspareunia, chronic pelvic pain, and abnormal vaginal bleeding, postcoital bleed, intermenstrual bleed, or menorrhagia can be a symptom of pelvic infection disease. We are only worried about the pain, but menorrhagia, and we are always thinking about hormonal causes of menorrhagia, but we should not forget that there is an element of infection in case of menorrhagia. Abnormal vaginal or cervical discharge, which is often purulent. Now, when I talk about vaginal discharge, abnormal vaginal discharge, let us go to a basic teaching of vaginal discharge. I've particularly kept this slide of vaginal discharge only to tell you what is normal vaginal discharge and what is abnormal vaginal discharge. Normal amount of odorless white discharge with no itching is physiological, and the patient is best reassured in such cases. If it is non-infectious vaginal discharge, that is like a foreign body, a polyp, or allergy, you can just counsel the patient for that specific pathology. A running white discharge occurs, and that is leukorrhea, occurs at birth, during puberty, or with oral contraceptive pills, and the cause can be best counseled and treated. Now, coming to the abnormal vaginal discharge, when there is an increased amount of vaginal discharge where the patient has to make use of pads, and when there is a malodor with itching and discoloration, that is a pathological discharge. So when you find a pathological discharge on a speculum examination, try to find out what type of discharge it is, because it is clearly visible to your eyes. And once you find out the discharge, you come to a conclusion that this is so-and-so discharge, and you send it for examination. If you find a fishy odor discharge, which is thin gray in color and the vaginal pH is more than 4.5, do a whiff test with QAOH and you find clue cells, it is bacterial vaginosis. Then once you diagnose bacterial vaginosis, so clearly you have the treatment in front of you. Metronidazole can be given, clindamycin can be given. I will discuss the dosage and treatment aspect again in the further slides. Now, coming to if the discharge is curdy white discharge, and it is adherent, and there is pruritus, and you see hyphae with KOH, it is Candida albicans. You have fluconazole creams and chlorpromazole creams and fluconazole tablets orally. So you can use, if you are using a higher concentration, you use it for less number of days. If you are using a lower concentration, you use it for a more number of days. Now, profuse, if there is a profuse malodorous pruritus, yellowish green strawberry colored vagina, discharge with strawberry colored vagina, it is trichomonas vaginitis, and you have the diagnosis and you can treat it with metronidazole. Now, if there is a cervical mucus ectopion or erosion of the cervix on speculum examination, or you find Nabothian cyst because of chronic cervicitis, and the cervix is tender with a lower abdominal pain, and when you do a bimanual vaginal examination and you find tender cornices, think of cervicitis, and cervicitis is generally due to gonorrhea and chlamydia. These two infections are the ones which ascend upwards into the uterine cavity, into the fallopian tubes, thus causing pelvic infection disease. Just for reminding you, pelvic infection disease is an inflammation of the upper genital tract. That is the uterine cavity, the fallopian tubes, and the ovary. You can, once you find gonorrhea or any of these infections, you can take a pap smear also, do a colposcopy guided biopsy if you find an erosion, and go for local therapy. Once you find the infection, treat the infection, go for local therapies like electrocautery and cryo. Azithromycin 1 gram orally in a single dose or 100 milligrams doxy BD for 14 days is given for gonorrhea as well as chlamydia. And don't forget to treat the partner in case of abnormal vaginal discharge. So having known the symptoms, now let us go for the signs in case of pelvic infection disease. What are the signs we see in pelvic infection disease? Fever, lower abdomen tenderness, and tender faunesis with an abnormal vaginal discharge. Just like you can see in the picture, there's a pouting vaginal, purulent vaginal discharge through the cervix in case of cervicitis. When the cervix is as shown in the picture, just think of gonorrhea and chlamydia because these two are the most important causes. Though the clinical signs and symptoms lack sensitivity and specificity, we have to take a few of the symptoms and signs into account and further diagnose with the diagnostic technology which are available to us. Coming to the differential diagnosis. Once you come to a conclusion that this is a pelvic infection disease, you have to rule out other causes of lower abdominal pain. Now, what are the other causes of lower abdominal pain? One is ectopic pregnancy. In ectopic pregnancy, you have a clear-cut adnexal sac on the adnexia and an empty uterine cavity. Sometimes if they are associated with heterotopic, you can have an intrauterine as well as an extrauterine pregnancy. So if there is an intrauterine pregnancy, it doesn't mean that there is no ectopic pregnancy. So always make it a habit to do an adnexal scan in early pregnancy so that you rule out heterotopic pregnancy. If there is an ectopic pregnancy, the beta HCG titer is raised and the UPT test is also positive. So that way you can differential diagnose an acute from an acute PID. Ovarian accident, I would like to tell about torsion ovarian cyst and hemorrhagic ovarian cyst. Infected ovarian cyst, yes, you can already diagnose on ultrasound clear cut with internal echoes, but you have to differentiate it from an endometriotic cyst. In endometriotic cyst, the echoes are uniform and fine, granular, as well as in an pyogenic cyst, you find thick echoes with dirty white shadows and bands and echoes sometimes. Hemorrhage also shows bands and echoes, and a torsion ovarian cyst can be differentiated by putting on a color Doppler and seeing that there is no vascularity to that area. So that is how you differentiate an ovarian accident. Now coming to appendicitis, you again go by the clinical history of the patient. Fever, vomitings, right iliac fossa tenderness, elicit the signs and symptoms in case of appendix, and do an ultrasound to find out whether there is a blind end loop over the iliac vessels, which can be easily diagnosed in case of acute appendicitis. Irritable bowel syndrome with the psychological element is also there. Inflammatory bowel disease have to be differentiated by finding out the bowel symptoms. Urinary tract infection by doing the urine microscopy and finding out history of burning, micturition, or frequency of urination. And bowel torsion. Last but not the least is the psychosomatic pain. Now, if all these causes are excluded and if you don't find any other cause, think of psychosomatic pain. So I have told you how to differentiate it from the other causes in how to differentiate pelvic infection disease from the other causes of lower abdominal pain. Now, once the investigations are available to diagnose PID, but they lack sensitivity. So let us have some more tests to finally diagnose and come to a conclusion for which aspect we have to treat. Now go for the blood test. Do a complete blood picture. The complete blood picture, you have raised WBC count, the neutrophilia suggestive of acute inflammatory process, and a reduced WBC count, neutropenia, which is very severe. In severe infections, you have neutropenia, and in acute infections, you have neutrophilia. Raised CRP and ESR are other findings. Now coming to the microbiological tests, here we have Neisseria gonorrhea and Chlamydia trachomatis. I will discuss about these two. You can take, once you find a purulent discharge coming out through the cervix, you take an endocervical swab, put it in the transport medium, it creates blood agar or Theia Martin medium, and it must reach the lab within 6 hours. even if not so by 6 hours, at least by less than 24 hours. Otherwise, the viability of the swab will be lost. And they will culture the swab and give you the diagnosis of Neisseria gonorrhea, where you have an accurate treatment. Coming to chlamydia trachomitis, endocervical swab is sent similarly for chlamydia trachomitis, but the test done is NAT test, nucleic acid amplification test. It is more sensitive than culture in case of chlamydia, and they can be used as diagnostic or screening tests. And a non-invasive collection of these specimens of urine and vaginal swabs can also be done in case of chlamydia. Now, a word about pelvic tuberculosis. If I should talk little about tuberculosis, because if I don't touch tuberculosis today in pelvic infection disease, I don't feel that it is complete. So now pelvic tuberculosis, it can be an active tuberculosis or it can be a dormant tuberculosis. If it is an active tuberculosis, that is, if the patient is symptomatic, she will have complaints. Now, what are the complaints the patient will have in case of tuberculosis? She may have menstrual irregularity, a discharge per vagina, pain abdomen, a low-grade fever running every day, with ill look and ill health, a mass abdomen. She may present with a mass abdomen or a free fluid in the abdomen, hydrosalpinx, pyometra, and infertility. She can present with any of these problems. Once you feel that she is symptomatic, start investigating her. If the patient is asymptomatic, then you have to, and you feel that maybe she is having tuberculosis, maybe instantly by finding out something like thin endometrium, scarry endometrium on ultrasound, where there is a persistent thin endometrium and you have a doubt that she may be having tuberculosis. Then in such patients, you have to go for a past history. You try to elicit. If she is not symptomatic, you try to elicit from her. Ask her for any history of tuberculosis, whether family history of tuberculosis is there, or a persistent thin endometrium is there, or if she is having a recurrent pregnancy loss or recurrent implantation failures on IVF. So if you try to elicit, then you will find out a cause. Finally, you go for investigations when she is symptomatic. Now, what are the investigations you do in case of tuberculosis? Ultrasound and HSG. Ultrasound, if you have pyosalpinx or tubo-ovarian abscess or a free fluid in the pouch of Douglas, you can find out. Then you should suspect some pelvic pathology that is causing this infection. And especially in case of tuberculosis, there will be a persistent fluid in the pouch of Douglas, which is significant in amount on repeated ultrasound. Coming to HSG, you can find the typical T-shaped uterus which occurs because of the scarring of the endometrium. The cavity cannot be filled completely. So on HSG, if you find a T-shaped uterus, just have a high suspicion for tuberculosis. Now, once you confirm the diagnosis, how do you, the other investigations are endometrial biopsy. Do an endometrial biopsy and you will get a report from the pathologist about the Langerhans giant cells in the specimen. Laparoscopy, look for pyosalpinx, hydrosalpinx, pyosalpinx, and any tubal adhesions. Hysteroscopy, you can find out the cheesy, white, fibrosed endometrial cavity which is distorted and there is no proper ostial openings on hysteroscopy. If these investigations cannot guide you to the diagnosis, you have to go for the higher investigations like MRI, CT, and PET scan. And once you, how do you confirm the diagnosis of tuberculosis? In spite of all these, we have only confirmatory tests like TB PCR and expert gene test and AFP culture, which are the gold standard tests for TB, and a histopathological examination of endometrial biopsy. So once you confirm with these tests that these tests are positive, then only go for ATT treatment. If these tests are negative, don't go for an ATT treatment on empirical basis. So once you have diagnosed that it is tuberculosis, how do you manage these cases? We have the medical management, the surgical management, and the ART techniques once the infertility aspect sets in. So first line management, according to the WHO guidelines, because tuberculosis is a paucibacillary disease, we have to go for the standard regime of 6 months treatment. That is the first 2 months with 4 drugs and the next 4 months with 2 drugs. If the drugs are resistant, then if you have resistant tuberculosis, then add streptomycin injections weekly thrice. if it is if the disease is of a severe grade. And when to treat these conditions, when the tests are when the final gold standard tests are confirmed, then only you have to start treatment. Now when do you go for a surgical management of tuberculosis? When there is a hydrosalpinx or a pyosalpinx, unless it is removed, that pelvic pain will not subside. So you have to remove them. Then comes the surgical intervention. For tubo-ovarian abscess, for pelvic adhesions and peritonitis, and in case of Asherman syndrome, you can easily just histoscopic guided, you can remove the fibrous bands and keep them on occipils for 3 to 6 months so that they regenerate their endometrium. And once they regenerate their endometrium, you can think of going for the ART techniques. When do you go for ART? Of course, if there is a tubal factor, bilateral tubal block, you cannot do anything for such patients. You have to go for ART techniques. And if there is a severe male factor infertility associated with the female factor also, you have to go for ART. Now, age of the female partner, if she's of more than 35-40 years of age, think of going for an ART technique instead of wasting time regarding with her treatment protocols. Now, third-party reproduction comes when her uterus is very badly scarred. So this is the management for pelvic tuberculosis. Now, what are the radiological investigations we have? Ultrasound. Ultrasound, yes, definitely it is helpful in case of pelvic infection disease. It gives you, though gives you an indirect evidence, it is insufficient to support the routine use because you won't have a specific diagnosis in ultrasound. You can only just tell that there is pelvic infection in the pelvic infection. But you cannot tell which type of infection, whether it is chlamydia, gonorrhea. So finally, the histopathological report and the microbiology department has to help us in diagnosing a specific pelvic infection disease. Presence of an adnexal mass or hydrosalpinx or pyosalpinx or a persistent, I'm repeatedly stressing that a persistent free fluid in the pouch of Douglas is a suspicion for pelvic infection disease. A little amount of fluid, don't suspect pelvic infection disease because, and try to find out in which phase of the cycle she is, whether she is in the follicular phase or at the time of ovulation, you will find a little amount of fluid. For 2 to 3 days, sometimes it is there in the pouch of Douglas. That will be around 3 to 5 ml. For that 3 to 5 ml, don't suspect pelvic infection disease. You have to suspect if the fluid is in a significant amount and if it is persistent. And if you find a tubal pathology associated with it or an ovarian pathology like ovarian cyst, hemorrhagic ovarian cyst, a torsion ovarian cyst, a hydrosalpinx, a pyosalpinx, all these can be detected on ultrasound. Coming to laparoscopy. Laparoscopy, yes, strongly supports the diagnosis. It's nothing like seeing and doing. Like you can see it clearly that there is a hydrosalpinx, a pyosalpinx. It is not routinely done because of its cost and invasiveness. The Fischer-Curtis syndrome, which is seen in case of gonorrheal and chlamydial infection, is very clearly seen on laparoscopy. When you put the scope towards the liver, you can see the string of fibrous bands running from the liver to the peritoneal surface like a typical violin string appearance. This is seen in gonococcal and chlamydial infections. Now coming for the screening for sexually transmitted infections. Now, who are the people who have to be tested for sexually transmitted infections? Those who have tested positive for gonorrhea and chlamydia, yes, they have to go for a screening test for STIs. Now, women at high risk of STIs are women with multiple sexual partners and a previous history of STI. The other investigations you have to do for them is HIV, VDRL, hepatitis B. And remember to screen the husband or the partner. Now coming to the infertility aspect of pelvic infection disease. Yes, it is an amalgamation of symptoms, signs, and basic office-based testing that you have diagnosed a pelvic infection disease. And having known that vaginal discharge is so important common symptom in gynecological outpatient department, it should not be ignored or taken lightly at all. Just keep a speculum, you have diagnosed a white discharge, treat it. Don't ignore it because later it causes long-term sequelae on the fertility of the patient. It can rarely lead to contamination of the cumulus oocyte complex or the follicular fluid that is aspirated in oocyte pickup, but it definitely affects the fertility when the infection ascends through the cervix into the cavity and affects the endosalpinx. It has a very bad long-term sequelae on the fertility aspect of that patient. Vaginal discharge, cervical mucus, or any bleeding due to cervicitis can plague or block the embryo transfer catheter tip and jeopardize the crucial embryo transfer step. Therefore, for women undergoing assisted reproductive procedures, evaluation of vaginal discharge is a part of mandatory initial assessment. If you find a vaginal discharge, treat it and then only go for the ART procedures. Now, what does ACOG say? 1 in 10 women is with PID becomes infertile. So pelvic infection can cause scarring of the fallopian tubes, and this scarring can block the tubes and prevent the egg from being fertilized. Now, coming to the pathways or spread of genital infections, in gonococcal and chlamydial salpingitis, the microorganisms, why I am stressing this in highlighting this part is gonococcal and chlamydial infections ascend by surface extension from the lower tract through the canal to the endometrium and fallopian tube. So the endosalpinx is affected directly. Microscopically, the endosalpinx is inflamed and edematous, and there can be additions of mucosal folds, destruction of cilia, and occlusion of the infundibulum and production of a pyosalpinx. The gonococcal infection may spread beyond the endosalpinx with possible focal abscess formation and salpingitis. Now coming to mycoplasma, it is a little different from gonococcal as well as chlamydia. In some cases of non-gonococcal salpingitis, particularly mycoplasma hominis, the pathogen enters through the cervix or the endometrial cavity and spread to the parametrium and tubes via lymphatics and blood vessels. So here it is through lymphatics and blood vessels. And in gonococcus, in gonococcus and chlamydia, it is through the cervical canal. So that is the point that you have to be stressed. So the inflammatory swelling that affects the parametrium and the tubes is more pronounced in gonococcal, but the endosalpinx is intact in case of gonococcal, in case of mycoplasma. So here I would like to tell you how the interrelationship of sexually transmitted agents and endogenous organisms in the pathogenesis of tubal fertility affect and cause PID. So because of the procedures done in the obs-gynae department like abortions, DNCs, IUD insertions, and other gynec procedures, all these procedures stimulate the endogenous polymicrobial flora and thus cause infection. That is, the inherent flora is disturbed and replaced by another bacterial flora which is pathogenic. This causes the bacterial vaginosis, and this bacterial vaginosis, this infection in the vagina and the STD agents from outside, all these together cause cervicitis, endometritis, and starts the initial tubal damage. Then there is a compromised host resistance causing salpingitis. And once salpingitis test has arrived, if you treat it early, there is restoration to normal anatomy, or there can be total tubal desolation or tubal occlusion and pelvic adhesions and pelvic abscess, and thus leading to infertility. So the surgical prognosis for pregnancy is uniformly poor in patients with flat tubal mucosa or fibrotic and thick-walled hydrosalpinx. That is stage 3, stage 4 of pelvic infection disease. Per prognosis, you have to treat the patient with IVF techniques if she is an infertile patient. Severe male factor combined with tubal disease in the female partner is an indication for advanced lab techniques in assisted reproductive technology. Now, it is widely acknowledged that pregnancy outcome after tubal surgery is time dependent. That is, once you have done a tubal recanalization surgery, how long do you wait for her to conceive? You wait for the next 6 months to 1 year. Let her try and see whether she is going to conceive normally. If she cannot conceive normally, that means that the cilia of the tube are damaged, and you advise her to go for IVF after 1.5 years. A review of the world literature indicates a mean intrauterine pregnancy rate of 58% after tubercorneal anastomosis, with an ectopic pregnancy rate of about 4%. Now, it is reasonable to expect a continued improvement in pregnancy outcome for IVF procedures. Data from the US centers indicate a 40 to 70% cumulative delivery rate after 3 IVF cycles in a young woman with tubal disease without associated male factor infertility. Now, effect of acute AGOG, American Journal of Obstetric Gynecology, has kept an article which shows the effect of acute pelvic inflammatory disease on infertility. In this study, 415 patients were studied for a period of 10 years. In this, 88, that is 20%, were involuntary childless after 1 or more infections. Tubal occlusion was diagnosed after 1 infection in 12%, after 2 infections in 35%, and after 3 infections in 75%. So the more the infection rate, the more the percentage of involuntarily childless fertility factor. So tubal occlusion was more common after non-gonorrheal than after gonorrheal salpingitis. So infertility varied with the inflammatory changes seen at laparoscopy. Now coming to the Journal of Clinical Investigation, and what is, now we are going still into depth about what is vaginal microbiome and sexually transmitted infections and epidemiological perspective. Now let us see what is bacterial vaginosis. It is a common clinical syndrome in which the protective lactic acid bacillus that is present in the vagina, that is Lactobacillus genus, is supplemented by a diverse array of anaerobic bacteria. So the normal flora is being replaced by pathogenic flora. So once it is replaced by pathogenic flora, it itself becomes an independent risk factor for severe reproductive tract and obstetric sequelae. That includes, again, preterm deliveries, low birth weights, and development of pelvic infection diseases and acquisition of STIs and transmission of HIV infections. All these come into play because the viral replication is very high when there are already pathogenic bacteria in the vagina. So this picture shows you, in the center, you can see the Lactobacillus crispatus and other mixed lactobacilli and the Lactobacillus iners. So whatever the lactobacilli that are inherent in the vagina have to be in the vagina. If they are replaced by pathogenic bacteria, then the infections set in. Like if the fungal infection comes, the candidiasis, and pathogenic colonization by Staphylococcus E. coli, or the anaerobic infections, which I have mentioned to you about the bacteroids, the Peptococcus, all these infections set in once the pH of the vagina is changed from 3.8. Normally, it is 3.8 to 4.4. Once the pH is gone to more than 4.5, this occurs because of low estrogen content, especially at the extremes of ages. That is why the infection rate is higher at the extremes of ages, when the estrogen content is low. So when the pH of the vagina is altered, you have the pathogenic bacteria entering into and replacing the normal vaginal flora, which causes these infections. Once you see these infections, I have told you, you have to treat them promptly. So microbiota and pelvic infection disease, there was another article published where you have the Nugent score. The largest longitudinal cohort study was done on 3,600 women for a period of 1 year. And they have shown that intermediate and high Nugent scores were associated with an increased risk for trichomonal, gonococcal, and chlamydial infections. Bacterial vaginosis promotes the ascension of bacteria from the lower to the upper tract, or the bacterial vaginosis may be an indication of upper genital microbial tract colonization. That means whenever you see that the vagina is infected with bacterial vaginosis, that means there is an inherent upper genital tract infection. So you have to treat it promptly. Now, pathophysiology of vaginal balance in female fertility. Now, what is happening in the vagina in case of female infertility? What is the pathophysiology behind female infertility? There is an increase in the concentration of interleukin-1b in the vaginal environment. When there is an increase in this interleukin-1, then you have the triggering the generation of reactive oxygen species. Now, this reactive oxygen species are the detrimental ones which affect the sperm motility. So they affect the membrane integrity and flexibility of the vaginal mucosa also, and at the same time, they impair both tail motion and sperm oocyte fusion. Thus, they affect the fertility and disrupt the fertilization and implantation process. So this is how an vaginal imbalance can lead to female fertility. So what happens when there is a disrupted vaginal microbiome? From conception to birth, there are all problems. Like starting from, if you conceive, first of all, for conception itself, it is a difficult process because the motility of the sperm is affected because of the bacterial vaginosis. Once it is affected, then once you conceive also, there are problems. You can have amniotic fluid infection, chorioamniotis, late miscarriages, early miscarriages, preterm rupture of membranes, preterm births, and low birth weight babies, and virus reactivation like herpes virus infections, cytomegalovirus infections, which causes abnormal pregnancies, and finally postpartum endometritis. So right from conception to delivery and even after delivery, you are suffering with this disrupted vaginal microbiome. So it has to be treated at the initial stage itself. Now, what are we looking for in the future? A healthy vaginal microbiota can help to prevent urogenital conditions such as urinary tract infections and bacterial vaginosis. Therefore, studies leading to a better understanding of the vaginal mycobacterium flora will facilitate the discovery of improved treatments and diagnostic for such conditions. Now, in future, we are looking for a vaginal specific probiotic. What are probiotics? Probiotics are substances which contain lactobacillus. They are used over a long period. They are used along with the antifungals as well as the antibiotics. So it is a co-prescription, particularly within the context of high infection recurrence rates. Now, vaginal specific probiotic. What should be the characteristic of a vaginal specific probiotic? It should be persistence in the human. It should be persistence in the human intestinal tract. They should be clinically validated and documented good health effects. They should have antagonism against enteric pathogens because they should be able to fight against the locally available pathogens. It is something like you are introducing a bacteria into your body, which is helpful, not harmful. So you have to fight with the harmful pathogens. Then they have to be susceptible to antibiotics because you're giving it as a prescription along with the antibiotics. And there should be safety in food and for clinical use. They should be acid and bile stable. They should be of human origin, and the production of antimicrobial substances should be of a healthy type. They should get adherent to the human intestinal cells. So finally, with these potential characteristics, the probiotic can help generating a good healthy microflora into the intestine, which affects the remaining systems in the body. Coming to prebiotic. The probiotic is something which you are introducing. Prebiotics are compounds that are found in the food that can induce the growth or activity of beneficial microorganisms. Suppose you take a sour milk or a sour buttermilk, you have so many of beneficial microorganisms in that. So these are the prebiotics. So prebiotic and plus a probiotic together is symbiotic. It gives you a good effect. So prebiotic, what should be the characters for the prebiotic is it should stimulate the growth and reproduction of useful microflora. It maintains an optimum pH in the intestine, stimulates the body's immune system. It should remove excess mucus from the walls of the intestine and reduce the formation of gas and suppress reproduction in the intestine of pathogenic bacteria and stimulate a healthy peristaltic movement in the bowel. So together, pre plus probiotic give a symbiotic effect and good healthy microflora to the immune system of the body. The vaginal microbiome as a predictor in IVF with or without ICSI outcome. So we therefore wanted to answer the following questions. What are they? Is the presence or absence of a certain bacteria associated with failure to become pregnant after an IVF or ICSI procedure? Yes. Can the composition of vaginal microbiome be used as an independent predictor for IVF or ICSI outcome? Both of the answers are yes. So our results indicate that vaginal microbiome profiling using the ISPRO technique enables stratification of the chance of becoming pregnant prior to the start of an IVF or ICSI cycle. Knowledge of the vaginal microbiota enable couples to make more balanced decisions regarding timing and continuation of their IVF ICSI treatment cycles. They definitely have a improvement in the pregnancy rate and live birth rate, because once the vaginal microbiota are treated properly, then you can have a good conception rate and a good ongoing pregnancy rate. If you are suffering from infection, I have just mentioned to you, you will be suffering with along with the patient with all the PROM, PPROM and chorioamnitis and all these infections. You have to go through all this. So conclusions: differential composition of vaginal microbiome, but not of seminal microbiome, is associated with successful intrauterine inseminations in couples with idiopathic infertility. Specifically mentioned, not seminal microbiome. It is the vaginal microbiome that gives you a good successful IUI pregnancy. So a good pre-evaluation for pre-IUI evaluation in infertile couples for her vaginal microbiota is very important for your success rate. So abnormal vaginal microbiota may be associated with poor reproductive outcomes. A prospective study conducted in IVF patients showed that vaginal microbiota has to be treated earlier prior to fertility. Now, evidence shows that endometrial microbiota has an effect on implantation success or failure. Now, here I am mentioning about endometrial microbiota. Vaginal microbiota is something different from endometrial microbiota. You can't think that vaginal microbiota is, vagina is suffering from this infection, so endometrium is having the same infection. Endometrium may have a different infection. So if you are suspecting endometritis, go for a biopsy, seek for the infection and treat the infection. That gives you a good successful reproductive outcomes in your IVF patients. Now, what are the means of management? Start treatment as early as possible. This is the one which I am stressing from beginning, because this is to prevent the long-term sequelae like ectopic infertility and chronic pelvic pain. Now, what are the general measures? Rest is best every time. So rest is advised for in case of severe disease. Do a UPT test if she is pregnant. All the more be careful regarding use of your drugs. Give her appropriate analgesics to relieve her pain. Ask her to avoid unprotected intercourse until complete treatment is over, and contact tracing and treat the partner or the contact person is also important. Treatment. Low threshold for empirical treatment PID is recommended depending upon the severity. Now, broad spectrum antibiotics are required to cover Neisseria, chlamydia, aerobic and anaerobic bacteria, because there are so many bacteria that are involved in the infection. Outpatient is as effective as inpatient treatment with clinically mild to moderate pelvic infection disease. Now, what are the antibiotic regimes we have? A cefotriaxone 500 mg stat dose of intramuscular injection, followed by doxy BD and metrogel BD for 2 weeks. Insist that the patient is taking the treatment completely for 2 weeks if she is a symptomatic patient. Don't just give her 5 days, 4 days, 3 days and stop the treatment. It is a complete 14 days course and a BD course, doxycycline BD, metrogen BD. I insist again and again. Ofloxacin, or you can give ofloxacin BD or metrogel BD for 2 weeks. If she is allergic to the above drugs, then you can go for a alternative regimes like IM ceftriaxone 500 mg stat dose, azithromycin 1 gram a week for 2 weeks, or moxifloxacin 400 OD for 2 weeks. Now, what are the inpatient regimes? When do you admit the patient, and what are the inpatient regimes? In case of severe infection, and if she is having an adnexal mass suspicious of an abscess, or there is a generalized sepsis, or she is not responding to her oral treatment and suffering from severe pelvic or abdominal pain, in spite of you using strong oral analgesics as an outpatient, admit her. Go for the inpatient regimes. Intravenous therapy should be continued 24 hours after clinical improvement and followed by oral therapy. 24 hours after clinical improvement, not after admission. So the regimes are IV ceftriaxone 2 grams OD and doxy followed by oral treatment again doxy BD, metrogel BD for 2 weeks. Once you discharge her, again keep her on oral treatment for 2 weeks and then ask her to review again after 2 weeks. You can give IV clindamycin 900 milligrams TID or IV gentamicin as loading dose 1.5 milligrams per kg TDS followed by clindamycin tablets QID 450 mg or otherwise doxycycline and metrorogel again for 2 weeks. Alternative regimes are ofloxacin metronidazole and ciprofloxacin doxy and metronidazole. IV treatment. Now, when do you go for surgical treatment? Surgery should be considered in the following situations: when there is an emergency situation like a torsion ovarian cyst, torsion hydrosalpinx, torsion pyosalpinx, generally there is pus draining out. But when you go for pyosalpinx, you have to be careful that the remaining peritoneum is not getting infected. Lack of response to oral therapy, you have to go for surgical treatment. And when there is clinically severe disease, presence of a tubo-ovarian abscess and intolerance to oral therapy. Pregnancy, and when the condition has to be relieved in an emergency situation, you have to go for surgery. Laparoscopy, you can divide the adhesions and drain the pelvic abscess. And laparotomy, you can do a digital division of all the adhesions and any loculated areas of abscess formation. Ultrasound and guided aspiration can be done for small abscesses and any collection in the POD. And it is because it is a less invasive procedure, and send the pus for culture. Don't forget to treat the partner, because the current male partner of the woman with PID should be contacted and treated, offered health advice, and screening for gonorrhea and chlamydia is a must. Simultaneously, they have to be screened for the other sexually transmitted infections like HIV, VDRL, and hepatitis B, C. IM ceftriaxone 500 milligrams status is given. Avoid sexual intercourse until the treatment is completed is a very important point. How do you follow up these patients? Review them every 2 to 4 weeks to ensure adequate clinical response to the treatment, compliance with oral antibiotics, and screening and treatment of sexual contacts, awareness of long-term sequelae of PID, and repeat UPT if indicated. Repeat testing for gonorrhea and chlamydia after 2 weeks in those with persistent symptoms. So finally, to stress, we all repeatedly, I would like to stress that good clinical history, clinical examination, a per speculum examination, a per vaginal examination will clinch the diagnosis. You can come to a conclusion with these aspects, then go for the diagnosis. Ultrasound is a right-hand tool for everybody to diagnose any pelvic infections. And in spite of all these investigations, still in case of the TB, tuberculosis, you can go for TB PCR, expert gene test, and acid AFP culture. So these tests will guide you to a specific infection so that you can treat them, but treat the patient at the right time so that she is benefited without the long-term sequelae. That is the sincere advice and carry home message for this topic today. Thank you.
Thank you very much, Madam, for this nice presentation. Just give me 1 minute time to check if any question is there.
Yes.
Madam, one question is, so what is your practical experience on how we could face this PID in case of pregnancy? Is it possible?
Pregnancy, how can you detect PID? Yeah?
Yes.
How
yes,
can
ma'am.
you?
Yes, ma'am.
Yes, definitely, because in pregnancy, you have to see whether, again, the same pathology. First, you do an ultrasound, because first you take a CBP total picture. If there is a severe neutrophilia, acute infection is there, then you can go for an ultrasound and see for any adnexal pathology, whether there is any hydrosalpinx or ovarian cyst, or any other pouch of free fluid in pouch of the milk. Because normally you don't see these things in pregnancy. Normal pregnancy is the uterus with the gestation sac. And if there is any pathology inherent to the pregnancy, like if there is any retroplacental clot or chorioamniotic bleed in the pregnancy, you can easily find out in ultrasound. So that is the cause, that should be the cause for the lower abdomen pain in case of pregnancy. And tubal pathology and infective pathology is usually towards the flanks. The pain is towards the flanks. In pregnancy, which is causing pain to the uterus, is usually towards the midline, and you can find out on ultrasound whether there is any pathology that is pertaining to the pregnancy. So that is how you can diagnose a pelvic pathology from intrauterine problem. And any myometrial contractions can also be seen on ultrasound if you have just keep the probe for some time.
Thank you. Thank you.
If it is a myometrial contraction, you have to give progesterone supplements to relax the uterus. I hope I answered.
Thank you. Yes, madam. And another question, ma'am. Ma'am, how frequent can you get this PID in case of this pregnancy, or means in the upper younger time of life period is
yes. The infection rate in pregnancy is around 15 to 20%. So we have actually when the patient is coming for fertility, if she is already pregnant also, there is a culture in the Western countries of taking a high vaginal swab and seeing for any bacterial vaginosis like streptococcus and staphylococcus. Any infection has to be treated earlier. So there is a high incidence, and that culture is there in Western countries that they take an initial high vaginal swab for all the pregnant patients, but it is not practiced in India. But we also should practice, because nowadays we are having many cases of PROM and PPROM. So one of the cause could be the altered vaginal microbiome. So this cause has to be ruled out. So when you have to rule out this one, you have to take a high vaginal swab and send it for culture and find out whether she's suffering from any infections. Especially, at least in cases of recurrent miscarriage, you have to take a high vaginal swab, because maybe it is one of the cause, infection is one of the cause for her to have a recurrent miscarriage.
Thank you. Thank you. Thank you very much, ma'am. So, ma'am, thank you very much. I could not find any other question right now.
Okay.
So thank you once again for your valuable time on Shield Connect, and in future also I look forward for some valuable session with you, ma'am. So thank you very much, ma'am. Have a good day.
Okay. Okay. Thank you.
Thank you. Thank you very much, ma'am.